Welcome to the next episode of the Last Visit First podcast. Today, I get to welcome Dr. Katy Lanz. She's one of the nation's most respected innovators in serious illness, geriatrics, and home-based care. A doctor-trained, triple board certified, advanced practice nurse, she has played a pivotal role in shaping this field. From her leadership at Aspire Health to advising CMS to national health plans and leading health systems and next generation models of healthcare. Katy is a devoted mom, a wife, and a friend of mine. She's grounded her work in humanity, compassion, and real-life relationships that define great care. Her voice, perspective, and leadership continues to influence how industry supports people through serious illness and the most vulnerable moments in life. Welcome to the podcast, Katy.
Thank you. And thanks for saying all that.
Yeah, it's awesome. I'm glad you're here. Let's start out. Tell us about you. How did you get from Vanderbilt to advanced illness to home-based care?
Yeah. Well, I think everybody's got their story about their why and what brings them here. And I'd love to say there was like one thing that brought me this direction. I mean, it's not always, our field is not one of the most desirable, right? When you look at the clinical choices as a young nurse entering the field or a young doctor, like, why do you do it? But for me, there was a few reasons. There wasn't one single, it was like death by 1,000 paper cuts around me. And one of the things, my grandfather was really sick when I was young, and I watched my grandmother struggle. He had cancer, renal cancer. He was a veteran, and just the system, the way it worked for him, the way it didn't work for him, Tom, and watching how his goal was to stay home. And then in the end, for him, when it got to the end, Duke was close by. I grew up in North Carolina. You'll hear the Southern accent through this. For anybody that doesn't like it, just keep scrolling, but you're going to hear it. And um, I think, for me, it was really about what was broken in that experience that drove me towards it, but also that I wasn't afraid. I wasn't afraid to touch the tubes, to ask why, to help my grandmother clean things up when we needed to. And my mom and dad would always, oh, you're going to make such a great nurse one day. So I think that's really the crux of where it started. And then just watching my own experience and how floppy it was. The ER was cool too. Like always, it's just like watching TV, and I'm like, oh my God, that looks so cool to be able to help people in crisis. So those are probably the two things of where it started. But like why end of life, and I'll make it quick on this one, is that once I started working in the ER as a young baby nurse, like in my, you know, early 20s, I didn't last too long there because I kept watching people come in and, specifically from the community who are declining, and they clearly were declining, but nobody was having a conversation about the reality of their disease. Nobody was offering an alternative choice. And it was also kind of perverse incentives, by the system, like, let's just keep bringing them in, nursing home back, nursing home back. And in the late 90s, early 2000s, like there was no disincentive to do that. So I think it was
Right.
all together. Long answer, but there it is.
Yeah, it was awesome. What branch of service was your grandpa in?
I actually don't know, but Marines in general, and he I would say I think he did a ton. All the pictures I see of him were carrying missiles and driving trucks. So whatever
Good.
that was, that's what he did.
Well,
Yeah,
thanks
yeah.
for being a family member of a service. I served for 10 years, and so it's super passionate. And I, love all the people that served. And we do a okay job taking care of veterans at the end of life. I don't think it's good at all, and so I think we can continue to do better. And I know the VA is really working hard on that, but it's something. Well,
Yeah.
cool story. I
Yeah.
love it. So Aspire Health, just take me back to Aspire. How did you get to Aspire, and tell us all what you guys did there, and then we'll continue to advance your career.
Yeah, that's a big jump because when we in healthcare, there's like this traditional ladder, right, Tom? Like you go to a great school and you get your degree, and then you likely work in a health system, and there's like you might either go in the education route of healthcare, or you might go into the business route of healthcare, leadership, maybe research. There was no like, oh, here's this world of venture-backed innovation where you can actually disrupt healthcare and create different payment strategies or different clinical models outside of like they don't teach us that in school. And
That's right.
so I didn't know that it actually existed until I was working at UPMC with Bob Arnold and Denise Stahl, 2, great, mentors to me early in my career when we were starting to evolve palliative care. And I got this phone call, like, the Center for Medicare and Medicaid Innovation was built. And we were like, "Oh my gosh, this is a place the government's actually paying for alternative strategies." And this is
Okay.
like 2011, 12, right when Obama came in.
Right.
And so we paid this junior to write an RFP for it. We ended up getting a $20 million grant to reduce avoidable hospitalizations. And what happened is the venture capital world saw the impact of that and said, "Hey, why can't we do this with Medicare Advantage?" So my phone rings, Brad Smith, Bill Frist, and they're like, "Hey, this is what we're trying to do. We'd love for you to help us with our clinical model and potentially serve." And at the time, I'm like, "Why would I do that? I'm at the top of my game at UPMC. I have this big grant." And then they told me their vision for spreading it nationwide and the scale at which it could reach, and I couldn't say no. So I served as their chief clinical officer, helped build that clinical model and build the teams throughout the country. Yeah, I could go on and on about that. That's a whole nother podcast, but whatever
I
you
know,
wanna.
but I want to know a little bit more about it. So, what were y'all really trying to do? Because Aspire is an icon in our industry for many, many, many years, and everybody aspired to be Aspire. And but what were y'all really trying to solve? You weren't doing home health, you weren't doing hospice, you were kind of in the middle there. So, explain that a little bit to the listeners.
Yeah, we knew that there was, the health plans knew, let's just say that. The health plans and the federal government knows that in those last couple years of life, that's the riskiest pool of business for them because their serious illness happens before we're eligible for hospice because we've done a really great job in our country helping people live longer. Like this, so the sloppy, unpredictable period for a health plan is in those last couple years of life. I just happened to have the right skill set at that time of knowing how to manage that population, right? It's not like I was born to do business in this world, but like it just happened. And so how can we avoid, in my opinion, that unwanted, unnecessary stuff that people don't want? They want to stay home. How can we capture them early and then make sure that they have supportive services and then have a warm handoff to hospice? That was the goal. We already knew that traditional palliative care was a loss leader in terms of, we could maybe break even billing fee for service on that. So it needed to be to scale it, a different model. And so we knew that the health plans might be the right partner because they cared about the same things that the patients and families cared about, which is avoiding that unwanted and unnecessary stuff. Um, so I'm not sure if that answers your question, but what the goal was is to build demonstrate that and scale it widespread.
So,
And
it was all physicians and nurse practitioners going to see patients in the home at the end of their
yes,
last few years.
the clinical model was highly medical at the time. Ask me if I feel like it should have been. Now, no. But in order to get in the front door, I think it was at that time needed to be, a medical central model where we were having deep goals of care, co-managing with the primary care, the symptoms, I would say even those hard goals of care conversations that are more medically inclined, and then helping them plan for the future. We also served on call for them. So yeah, mostly symptom management, goals of care. I would tell you though, what we learned is about 80% of the needs of people when it comes to unwanted, unnecessary things are more socially driven. And our model evolved over time to be more socially integrated and add social workers. It was a really important, that's why palliative care is interdisciplinary, because no one discipline can do it alone. And I would argue not one human can do it alone.
I agree with that totally. And it's, I've been studying a ton on behavioral health and, whether it's drug addiction, alcoholism, depression, loneliness, sad. I mean, there's so many studies out there that once Papa goes, Nana goes soon, or once Nana goes, Papa goes soon. And it's really sad. But behavioral health's a big piece of this. And, unfortunately, under the home health benefit, if you're on home health, you have to be homebound in order to be treated under home health. And that's probably the last thing we want from somebody that's really depressed is to force them to stay in their home. And so that model breaks a lot. And so I think you're right with the palliative care, being able to put a social work in there, start working on the plans of life. What are you going to do with your stuff? I mean, I always make the joke of you have a dog over there, and when you pass away, what do we do with your dog? And I mean, what are we gonna do with your cat, your stuff, and then there's all the other pieces of it, like planning for the family and getting everybody around you to understand that you're, at the end of life. So stuff. I loved what you guys were doing. That model is a cool model, but um,
People,
it,
places, and things. That's what we used to call
yeah,
people.
people, places, and things. That's right. Yeah, all your things.
And
It,
it's
yeah,
complicated, Tom, and I never made that connection with behavioral health. It's a really good one, and so true. Every person's journey is individualized, and of our patients who were declining in the last couple of years of their life, which we worked with the health plans to identify, right? About 20% of them had some type of either behavioral health diagnosis, and most of the time it was some layer of depression because of, what was going on in their life. They were functionally, nutritionally, and cognitively declining.
for
Why
sure.
wouldn't someone be depressed or anxious or worried? That's a lot.
I I was listening to a podcast last week, and there's this new motto that I have actually inscribed it onto my mirror in my bathroom. It's I'm going to be the oldest guy at the gym, not the youngest guy at the nursing home. Think about that for a second. It's pretty good, right? So go
Do
work
love
out.
that, and I think we all want that. Let's get that sign and put it in
I
our
know,
office.
I know, but it's a good one. And but it's amazing how many people are when they're you're old, depressed, they're sad, they're lonely, they're sore, they've fallen, they don't go work out, they don't get up, they don't move, they don't exercise, and you just continue to decline and decline and decline. And you can only watch so much Price is Right or the Today Show or whatever, and that's going to cause you depression too. And then your family members are away from you, and now you're depressed. So I think there's a whole journey that we should all be thinking about. And I'm not old enough to be, the oldest guy or the youngest guy at the nursing home, but it's something I think about a lot now. And so that's my motivation.
And I'm glad you're thinking about it, but, like, just to push back on it a little bit, Tom, there's a time when in your mind, you wanna be the oldest guy at the gym, but your body might be failing you. There's nothing you can do about it. There's no
That's true.
control, there's no pill, there's no growth hormone for aging the way there's a time when our mortality hits all of us.
It does.
And there's nothing we can do about it, and it's how we respond to it. In fact, in Erickson's theory of aging, I'm sorry, I have to these degrees back here did count
Yeah.
for
Use them.
something. Like,
Use them.
yeah. So Erickson, the final stage of life, it's integrity versus despair, right? And that's what you're talking
Explain
about.
that. Explain
So
that to the crowd.
integrity versus despair is like the final phase of life. And so when we get there, we either are looking back with regret. We're worried about the future. We're angry about it, that this is happening to me, egocentric about the view of what's happened. We have regret and blame for what's happening to us, and our bodies are failing us, and our families are aging, and our friends are dying. Why me? Or the antithesis of that is gratitude for look at what I've done. You know, look at look at this beautiful family around me. Look at what I've created and the wake effect of my life. Yes, I'm going to die. And isn't that beautiful? And I, I'm not in control, but I know that I have the things around me and the relationships and everything's secure and safe in such a way that I can do this my way. Now that is, what we when we see talk about the good death in our world, that's the people that tend to just die beautifully, you know?
Yeah, it's an amazing. It's good. We had a family conversation. I don't know. It's been a year or so ago. I'll never forget it though. We were talking about would you rather die tragically quickly, just go like that, or would you rather be diagnosed with cancer and have a drawn out event, knowing you're going to die in the next 6 months and be on hospice? And it's everybody's different, right? It's where are you in your life? Would you rather say goodbye to everybody and make sure you cleaned up all your sins and made friends with the people that you were mad at over the years, or you just want to drop and go? And I'm torn by it. Like, I mean, some people say it's a blessing to be diagnosed with a disease and know you're going to die and be able to clean everything up. And some people say, I don't want to know that. I just want to go. I don't want to be a burden to the society or my family or whatever. And I think it's everybody's individual choice, but it's an interesting one.
Yeah. I think of somewhere in the middle.
I'm in the middle too. I don't want to be a burden to anybody. Like I don't, when things aren't working right, it's my time. Let's go. But I'm not ready to do that yet. All right. So you've lived at the intersection of clinical practice, innovation, and strategy. Those are three major hard words. How has that shaped your philosophy of how we deliver care today?
It's a unique perspective, I'll tell you that. Like when you, I started at the bedside. I started from a very mission-oriented place, and it is the foundation of everything I do. But there is a healthy pull on the systems thinking is required. So, like, as a nurse, I'm frustrated with the system. Why am I having to do all of this extra things? They don't seem necessary. Um, every time I got curious around that frustration and asked why, there's another perspective that's leading to it. I'm not saying it changed my frustration, but it gave me a systems perspective. Talking with the CFO about why we can't get a certain type of catheter, talking to the um the head of the hospital about why we can't expand our palliative care program and the business opportunity that we have to help reduce avoidable hospital. You get a perspective, and I'm saying all this to say, with that perspective, it helps you align strategy so much better and give better advice and build better models for how not just deliver the care all the way up from what the patient needs, but all the way up to how we get paid and how we scale it across the country. So, I encourage people. It didn't come overnight for me. This isn't something you just learn in a year. This is years, Tom, of being annoying and asking why, and gently leaning into people when you don't understand something, and sometimes even pushing back a little bit. Yeah.
Yeah, it's super frustrating as a taxpayer. I always worry about like, if a patient's on home health and you call the doctor and say, "Doc, we need to do something," he says, "Just send them to the ER. Just send them to the ER. Just send them to the ER." And it's like, why would we do that? That's the worst thing we can do for that patient. Some people need to go to the ER, right? If they have a fall or whatever. But if they're already on home health, instead of just really going and evaluating and seeing what we can do, we just send them to the ER. And going to the ER means you get a full workup, you get to wait in line, you get to sit there for hours, there's other diseases there. Not that all ERs are bad. I'm not bashing ERs, but it's not where Nana wants to go most of the time. And then they're going to admit you into ICU. And then then where are we going? Now we're going down a different path, and we're going to spend a whole bunch of money on Nana. And maybe she didn't want that. Maybe Nana just really wanted, someone to make sure that she didn't have pain, or maybe she was just lonely, sad, depressed, scared. And, but it's so often the response is call 911, go to the ER. It's tough.
Yep.
I struggle with that a lot.
I do
That's the
too.
systems breakdowns.
I think, there's litigation on one side of that will never completely go away, and I understand, but then there's also consumerism, and how do we often that go to the ERs because there's a lack of access somewhere, either to your primary doctor or, like, just this week, I have a close family member had low sodium. It was like, to the point where it was almost like, okay, this is getting, and she was symptomatic too with it, nausea and high heart rate. She didn't have a renal appointment for another week. So what did I say? Well, if you go to the ER, you're gonna probably see you're gonna get admitted, and you're probably gonna see a nephrologist within 24 hours.
Sorry.
So, if we can manage your symptoms at home and make sure this is headed in the right direction, let's do that, but otherwise, and she had me, so, like, most people don't, and I think you're right, like, and that's where I challenge our provider systems, like home health and hospice. What other products can you build that solve
It's
that
true.
need?
It's
What
true.
can we do to evolve our businesses to be there for people who are sick and getting sicker, but don't want to get in the system? And who cares about that? Well, health plans care about it. At-risk doctors groups care about it. And by the way, it's just the right thing to do. And if you can keep them out of the system and at home as a home health and hospice person, there's a likelihood of a referral at some point too. So I think it's not easy to do. I'm not saying just snap your fingers and do it, but I think we need to get creative a little bit in our industry. What do you
Yeah,
think?
I absolutely think that. And then there's the other side of it is once they get admitted and then getting them back out of the hospital. I had a few people over at the house a couple of days ago, and a gentleman that we know in Minnesota is really struggling with um, getting a care provider to care for him. He needs to be on hospice, and they handed a list of 25 hospices to the family and said pick a hospice, and she's like, "Oh, I don't want to pick a hospice that way." And so luckily they called my lawyer who was at my house, and they said, we need help. And he's like, well, I just happen to be at Tom's house. Tom knows every hospice in the United States. Let me help you. And so, I called the CEO of St. Croix Hospice, and the patient was admitted, right there. But the guy was literally in the hospital for 3 more days because they couldn't pick a hospice. They didn't know where to go, and they couldn't get one lined up. And so they wouldn't discharge him, rightfully so. You shouldn't discharge somebody out on their own. This guy really needed hospice care. And it was a really sad story, but all they had, if it wasn't for me talking to my attorney and, there had been a relationship there, who knows what would have happened. And and we're in this business and we make it hard. So can imagine if you don't know anybody that doesn't have, a Dr. Katy Lanz in their family, what are they going to do? She even called
Yeah.
911 and went to the ER. I'd like to also thank our premier sponsor, Telehealth. Telehealth is used on a daily basis to figure out where doctors send referrals as well as facilities. There's all kinds of data in the home health and hospice space inside of Trella. We use it a lot for acquisitions. So when we're looking at agencies that we want to be acquired or helping agencies create de novo strategies or market studies, they look at it to figure out, do you dominate a community or not? How many Medicare lives are in those communities? And then how many hospice or how many home health patients are there in those communities? Trella Health also has a CRM product that allows sales and marketing to have clinical intelligence as well as market intelligence to steer them in where they're calling, making sure they're doing the right amount of calls, as well as documenting their sales calls inside their product. You can find them at trellahealth.com. We'd like to thank Home Care Home Base. They're our premium sponsor as well. Home Care Home Base is the leading EMR in the home health and hospice space, serving over 50% of the patient population. What that means is every other patient is essentially on and being passed through the Home Care Home Base system. You can reach them at hchb.com. Please reach out. All right. You've advised national organizations and led a ton of work at the CMS Innovation Center. What policy dynamics should leaders be watching for in the future here, in the near future?
Right now, there's this big shift towards rural access. And I'm not sure the headwinds around that, other than perhaps maybe a lot of people in DC own businesses that are in these markets, or, it's a federal government, thing, but it's also about access. We are seeing a ton of rural hospitals close and rural systems. So I, in anticipation of that, there's mass when we're cutting costs like we are in home health, hospice, hospitals, the markets where they just don't have as much volume, they're going to start having to close their doors. And so I think in anticipation of this, we're going to see a massive influence of innovation in rural healthcare. The cool thing about that is that it will, that can be scaled outside of rural health and, the innovation that happens. So I'm excited to see what happens there. So policy wise, I hope we see a little bit more loosening around the telemedicine components, things that increase access or point of service care and reimbursement. And specifically, I hope we can leverage the home health, how we serve rural environments. If we speak up now to that, it might change the impact that we see on the cuts that we've been um,
For sure.
continuously been pushed upon us over the last few years.
Yeah, I got hit with that pretty hard. I was at a board meeting with Tango Health the other day, and a guy's father needed home health. And he's like, Tom, do you know any home health providers? And he was in the middle of New York. He's like an hour and a half north of New York City. And there's literally only, and I have a list of every home health provider in the United States, and I have it on a map. And so I zoomed in on the map. I'm like, yeah, sure, let me find somebody. I zoomed in on the map. There's one provider there, and they couldn't take him. They didn't have enough staff or capacity to take him. And he's like, what do I do? And I go, you need to go find a nurse and hire her and to take care of your dad. He's like, but I should be able to get him home health. And I'm like, there's no provider there. He's in a desert. He's in a home health desert. And there's one provider and they didn't have enough staff to take care of him. So they said, well, put him on a waiting list. He's like, my dad needs 24-hour care. He needs someone in the home a lot. My mother's passed away. And I felt terrible for the guy, but there's nothing he could do. He was going to have to go pay for it himself or hire somebody. I said, go find a paramedic or somebody that wants to come in and help care for your father. Luckily, this guy has enough money. He can do that. But I mean, there was literally no care for him. And they wouldn't discharge him. And they wanted to put him in a nursing home because he's like, my dad doesn't want to go to a nursing home is where my dad will die. He does not want to do that. And he's like, he wants to be home. He wants to, age in place. And there's nobody to take care of him. It's really bizarre. And you would think in New York that, an hour from New York City, somebody'd figure that out. Not a single home health provider.
It's a hard we think in our business in verticals, and then I would say keep doing that. That's your slow and steady up the middle for all my football fans. if you're thinking about how you scale outside of your market, it's like what pieces of your clinical model can you virtualize? What pieces of your model can you extend out? And what does that look like? Because it's hard to conceptualize. I understand that, but perhaps there's negotiation with I think that there's gonna be more negotiation power with reimbursement around these things and potentially even models that come forward.
Well, and we proved it worked in COVID, right? In COVID, it worked. I mean, we proved telehealth worked or telemedicine worked. Not the difference between telehealth and telemedicine. Make sure everybody understands that telehealth, I think about monitoring and blood pressure cuffs and all this kind of thing. Telemedicine is your doctor dialing in or your nurse practitioner, PA dialing into your house on a tablet in a secure connection and virtually taking care of you. That's amazing. And we should be able to do that for everybody. I agree.
Right? And Amazonization of the services too. So,
Yeah.
when you have a sore throat even in your rural America, you need medicine, like, you need it. So we've got to figure out, okay, if we can virtualize the actual diagnosis, as closely as possible, then how do we get the things that people need to them and teach them how to take care of each other in those environments? So when I was doing work with Dollar General, I was advising them, I guess it was a couple right after COVID for a couple years on their rural health play. This is another aha, and this might be a good segue, but they were seeing their biggest customers were sandwich gen women. And not surprisingly, the shoppers of the family, right? But that sandwich gen woman was not coming to shop as much in certain areas, and it seemed to be happening across America. Like, what is it? So they did some surveying of their BFFs, they call them, their best friends, that shop within the Dollar General market. And what they found is that she was leaving the workforce to care for either children or parents or both.
Wow.
And when she left the workplace and couldn't afford the groceries anymore or spend as much on them, there was a natural evolution of decline in sales for that Dollar General in that market in general. So what that told them is when caregivers break, communities break because they're having to drive, take time off of work, go into the city to get care, or they just don't have anywhere to send them, or they don't have a nursing home to send them to, so they're having to stay at home. And I think America's turning on to this issue and like seeing that this is going to be a huge problem. Um, if we don't start figuring out how to help that sandwich gen, primarily female, be able to stay at work and also stay strong in the community that they're serving.
So you're calling it a sandwich gin? I've never heard that term. What's a sandwich gin?
Really, Tom?
No.
Sandwich gen is the gen. You're in it. There you go. Welcome to the sandwich gen. It's the people who are simultaneously often caring for children and parents, and or they still have their parents and children alive.
Yeah, but
We're in that.
both of my parents are still alive. I'm very blessed. And my mom's in great health. My father is as well. So my dad's a avid fisherman, and yeah, we're very blessed with that. And our kids are still with us too, so that's great. I didn't know I was a sandwich gin.
You're a sandwich dinner, and you account. NORC just came out with a study. NORC NORC just came out with a study that said the most influence over the decisions that the octogenarians and nanogenarians will make today are from the children caring for them within the sandwich generation. They look to us about these big decisions, and we are the most influential. So as we're designing these dreamy products that we talked about, we really need to be thinking about the caregivers and the people who are making decisions for their parents and targeting them, and supporting them through it. Yeah.
Yeah, my sister and I always we've agreed that she gets my mom, I get my dad, and that we'll figure that out. But and I can't wait. It'll be a blast. It'll be a lot of fun. Neither one of them are any desire to go in. I mean, they're both great health, and they're in their 70s, which is awesome. And but they're getting that age, and we worry about it. We talk about it a lot. I talk to Mama every day, and I talk to Nana every day before Nana died. So it's super important that we communicate. It's short, I can't spend a whole lot of time with her, but I talk to her every day. I call and check on her. Just, are you okay? What are you doing? All right. You found a topside partners. You got to work with Dollar General, which is bizarre to me that Dollar General hired you to figure this stuff out, but that's awesome. What's the next generation of serious illness look like? What are you advising people on as you're doing your consulting work out there?
Wow. When I think about where serious illness is headed, let's the only reason, let's just talk about palliative care, not the hospice benefit, but palliative care. The only reason that the business of palliative care started to exist in America in the early, I would say mid 2000s, it became a board specialty for doctors, is because traditional fee for service required like us to see 30 patients a day as a primary care or geriatrician, right? And so we couldn't have the conversations that needed to be had. And so what happened was we had this huge blast off of palliative care in America. And it became, part of credentialing for hospitals and certifications, blew up. Then value-based care came. They're like, oh, palliative care actually helps save money too. Great. If we layer it on top of primary care, especially it helps. Now what we're seeing is health plans say, hey, doctors group, or hey, ACO, let's just talk about ChenMed, the big daddies or Oak Street, or big at risk, Landmark, Caремore. You primary care docs, you take all the risk. We're gonna give and share in the savings. So how has that impacted America as we see the at-risk primary care go up? We're starting to see the need for palliative care go down because doctors are able to do the work that they originally signed up to do a little bit better, which is that value care. So now what they still can't do is social supports. They still can't do personal care. They can't do urgent care in the home. So I'm seeing amongst the palliative care programs across the country and serious illness care, I'm seeing a lot of them shut down, especially if they're affiliated with hospices, because the referral streams are changing just a bit. Not everywhere, but in a lot of places. I don't anticipate that changing until, and this is high level, but those same doctors make money when the sicker the patient is. They call it the HCC scores, or how sick someone is. So when those doctors groups realize they actually have to provide more services for a really sick population, that's when they're like, oh crap, we need more. We need more support. So I do think that there will be a pendulum swing back up of palliative care as we integrate value-based care throughout our country, and we know CMS is going to do that because they've said it. To answer your question boldly, we're here to say we're in a hard time in terms of business of palliative care. Hospice is good, but we're about to see, I believe, a larger integration of serious illness models come back. And it might be specialized based off of what the patients are facing. And it might even live within some of these at-risk primary care groups, like Monogram or Upper Line or some of the others that are emerging along the way. Yeah.
Have you spent much time in ESRD in those kind of patients? Those are the ones that we see the most that are in stage renal disease. Are the sickest patients. They're the highest risk. They have the most, ER visits. These patients are in bad shape. And the sad thing is you can't be an ESRD patient and go on to hospice very easy because the doctor's not going to tell you to stop, dialysis, go on to hospice. As soon as they say stop dialysis, you're going to swell up and it's going to be bad. And then, but you can't get onto hospice if you and take dialysis at the same time. It's considered curative. And so we see tons of patients through our, the Mosaic products that the sickest of the sick that should be on hospice, they qualify, they have all the criteria, they meet all the local determinants, but they can't go on to hospice because the doctor won't stop dialysis. And until the government changes that, I think we're going to be in a real weird imbalance. And those are a lot of those patients that you're talking about that are on palliative care that need to go to hospice, should be on
Mhm.
hospice, but they can't.
Or the system doesn't support them right. You know, one of my biggest mentors, his name was Dr. John Lusk in Greensboro, North Carolina. He was an oncologist. He ended up going into palliative care in the early 90s before it was like a thing, and I worked at the local hospice. And he I don't want to talk too much about the end, but for him, but what he had COPD himself, and he actually said to me, sometimes a ventilator can be palliative, Katie. Sometimes dialysis is palliative. Think about it. Would you go off of palliative? Would you go off of dialysis or a ventilator if you still felt love for your family or you weren't ready to go? And so I think that's where palliative care really should exist. And until the system catches up with it where you don't have to give something up, um, like dialysis or a ventilator to go on hospice, that's the perfect place for palliative care.
I agree.
Yeah.
I agree totally. What else are you working on these days? I mean, I know you're always busy. You kind of retired. Yeah,
Yeah.
that was a lie. It wasn't. You didn't retire. You just slowed down a little bit and took care of your family a little bit. But what are you working on these days?
Well, it kind of if you stuck in through this whole podcast, you probably heard the culmination of what I really care about and understanding the systems, understanding how people think, understanding what's broken in America, understanding what we've seen across the country when we're building these value-based models. What I've been thinking about for the last 2 years, and I've titrated down my advisory work to make room for this, building a new company, and it's gonna be called LifePlans because right now there's no one-stop shop for people to go to help them plan for the future. And it shouldn't be about dying, and it shouldn't be about a service. There needs to be a third party, direct to consumer-esque model that helps people to via trust, create, store, and share what matters to them proactively, not reactively, so that, Tom, when you are in the gym, you know, the oldest guy in the gym, you have this digital plan so that when you have a heart attack on that bench, if that's how it goes, your family is so prepared and taken care of. And in order to do that, we need to meet the sandwich gen, and we need to meet them where they are and start thinking about our mortality early as we're caring for our parents. I know it sounds big
It's
and
true.
bold, and you know what? It is. And I'm scared to death half the time about it. But I'm excited to be able to start to create these life plans. I'm doing it with social workers and nurses that I've known along the way. Everything from diamonds to divorce, birth to death, everything in between. We need life plans. We need a third party partner to help us, figure those things out so that we can live freely and peacefully without that worry about the future.
That's awesome. And so this is like a technology or a program or it's a solution or what do you call it?
Life plans will be a platform with
Platform. I like that.
mhm, with it's a hub, have you, where people come to create, store, and share those important life plans for the future. We will have internal life planners to help support people through that as well. And that's the cool part is that,
It
you
is.
have a person that's with you to help you figure things out. And yeah, we will be referring a lot of people along the appropriate paths based off of the life plan that they're focusing on at that
That's
moment.
really cool.
Yeah.
I mean, I just think about it as you say that. I'm sitting here thinking about like, if something happened to me, how would Jennifer Maxwell figure all that? Like where passwords, usernames, social media. I mean, all the things that we have in our lives. I mean, it would take a long time. And the same thing with her. If something happened to her, there's no, I mean, it would take us forever to figure all that out. How are you going to solve all that? Where's your AA, your American Airlines, your number for your American Airlines miles, all the grocery stores, all the cards, I mean, oh my gosh, I can't imagine. It would just be, and so that's all the kind of stuff you're looking at. And I mean, there's got to be ways that technology helps us figure out how to store that and, kind of a break the glass. Here's the secret password upon when you need it kind of thing.
Or
It's
QR
amazing.
code. Dom will just send you a QR code. But,
That's right.
like, when we watch what happens to our families in hospice and palliative care, and that's, your primary audience out here is blended, but let's just think about it. Our clinicians are burnt out because there's only so much we can do in one day, right? We wanna get home to our families. There's a lot of documentation, there's the analytics, it's am I in the right place at the right time doing the right things? But we're walking away from families who don't just need medical things. They actually need this bigger, broader problem solved. And right now, with the way the system is legal's over here, finances over here. We've got, our real estate here and passwords here. And and those are the things that are keeping patients and families up at night. That they're
Sure.
like, and they're grieving at the same time. So our nurses and social workers and CNAs are walking out of the home knowing that this is what's weighing on our families' hearts, and they have no solution to offer them that is really helpful across the board. So we need playbooks and a hub to help people figure it out and connect people with other people who are trying to solve similar problems. And we need storage, digital storage of the things that matter most that you can share when you need it. And I think if you think about it backward, it creates a family operating system, Tom. If you do start it now, like these are things you can just share throughout your life. It doesn't need to be for when you die. Like it's just pulling it all together.
It's
Yeah.
true. I think I need it just for all my stuff. I mean, I have so much
Well, I'm
stuff
building it
I
for us.
forget.
Remember, you're in the
And
sandwich bin.
yeah, oh, the sandwich. That's funny. I didn't even heard that term before. Nobody use it. All right. Everyone talks about whole person care. In practice, what it is authentic whole person care require culturally, financially, and operationally. So this is kind of driving off of this business you're thinking about building, which by the way, I think it's awesome that you're going to be an entrepreneur and go do that. I mean, you've always been an entrepreneur, but taking the leap and building a software or technology or as you call it, a platform, which I like. It's big. Most people are too scared to take that risk.
Yeah.
So
Thank you
what's
for saying that.
yeah. Yeah. What's the whole person care? What does that mean? Everybody talks about whole person care. I always think about it as, it's spiritual, financial, and actual healthcare, but there's way more to it.
It's in the eye of the beholder. It's in the eye of whomever you say it to. And whole person care is when you understand what the whole person is and study that, right? And when you integrate the right strengths to be there for people based off of what they're showing you and the right services and the right time for those services. But in order to do all that, we have to understand what they need beyond just healthcare. We aren't just meat and bones. We are so much more. And when we look at like even just prognosis, it's not just what the disease tells us, like how ready is someone to leave this earth? Are what are their spiritual values and have they resolved those? Have they resolved their relationships? Do they feel at peace? Do they have integrity versus despair in terms of their aging? And that is, I think it's understanding where the person is and giving them the types of services that they need in that moment. And again, Tom, no one person can do that. Like
That's right.
we can try to overlap a little, but that's why interdisciplinary care matters so much. And if you can't be interdisciplinary, having partnerships and referral, friends in the network that you can help get to when people need it.
I also like to thank our sponsor, Maxwell Tech. Maxwell Tech is a consulting company that works in the mergers and acquisitions, optimization, implementation, and is also in the tech-enabled space. They have a product called NanaConnect. NanaConnect allows you to text patients' appointment reminders, check in on patients in remote patient monitoring, follow up on patients that have been discharged, as well as automate the entirety of the bereavement process. To get more information, you can email sales@maxwelltech.com or go to their website at www.maxwelltech.com. All right, I want to reach out and thank one of our sponsors, Steno Health. Steno Health is an AI ambient listening tool that makes clinical documentation much faster. Check them out at stenohealth.com. I also like to thank our sponsor, IntelliTriage. IntelliTriage is a human in the loop, nurse first triage company that simplifies the triage function inside of the home health and hospice community. You can reach them at IntelliTriage.com. So when we releasing this platform?
Well, I'm hopeful that we'll be testing it out in quarter 1 and we'll be going live in quarter 2, quarter 3 next year.
That's awesome.
Super pumped. And I hope that it helps my colleagues out there who, really want to help families with that planning, but we just don't have that skill set, right? We need a partner.
Yeah, it's amazing nobody else has done this, so I'm excited for it. Can't wait. I can't wait
I
to
can
see it.
tell you why. It's really freaking hard is what it is. It's
Yeah,
really hard, and it's taken 2 years for me to just kind of conceptually figure it out, so.
yeah, that's awesome. That's really cool. And it'll be, make sure that I get a first early copy and I'll be a customer for sure. I'm excited about it. All right. Are you going to put AI into it?
You know it. You
Of
know
course.
it. I can't talk too
Good.
much about how that's happening, but I can tell you AI is great and all, and these large language models are really cool, but unless you back them with the experts who understand the right way to approach families and the right product that needs to come out of us and its utility in our workflows or in the system, then you know what? It's not really worth much. But we can leverage AI for like many operational workflows and things like that. This is a little bit different. It's, coming
For
up with
sure.
and yeah.
But I also think about AI can help you just, create the check boxes of all the things that Nana's done. And over time, you can, you know, load up everything she's done and like, okay, where do we need to go figure out all these things? And how do I solve that? Do I have this password? Do I have that password? Do I close this account or that account? It can help us in all that for sure. That's cool. What else about AI scares you in our industry now? Or are you excited about it?
There's 2 things. One is that it's just gonna add a little bit of labor on our already burnout workforce, because it's not always completely accurate, meaning the integration of that. There's we don't often think about implementation when we build these really cool technologies. You do
True.
because you're a veteran and tech services and integration, but, most people don't think about that, complexity of how hard that is to integrate. So there's the change management function of it that can kill a product. Even the best of products can die at integration and implementation. So that's one thing. The second thing is the concept that it can completely replace the humanness of what we do and the analytics of how complicated are the patients that we are serving. So you know, for example, I built algorithms with Dr. Lasher and many others in the country that identify people, as sick. They're only right about, 60 to 70% of the time. You have to still touch people, look at them because you can't rely solely on this. Now, will it get rid of some operational inefficiencies? Absolutely. But it can never replace what we do at the bedside completely.
I agree.
And
We talked about
worry
that the other day.
people who are worried about the monetary side of the business will think that it can, and our patients are gonna suffer because of that.
Yeah, that's well said. I mean, I think it's if we can use it to make jobs easier and we can use it to, serve data up or remind us of things or summarize things and make that easier. AI can't give you a hug, right? AI doesn't have feelings. Even if they create these massive robots. And I was listening to a podcast this morning Elon was talking about, all his new robots that they're coming up with that can do all really cool things. And I'm all for that, in manufacturing and, deliveries. And I mean, pretty soon there's going to be, drones flying around with your delivery from Chipotle is going to land on your doorstep. You don't have to talk to humans, but you still have to have feelings, still have to have friends, still need people around us. We still need healthcare workers to go service patients. We still need to talk to people, explain things. AI is not going to be able to explain your end of life. Imagine you're having an end of life discussion with somebody. AI is not going to solve that, right? It's tough. All right. This is the Last Visit First podcast. What does that mean to you, Last Visit First?
Last visit first. Well, as a nurse, I have performed many last visits and been with people in the last visits of their life. And so for me, it resonates in that way of thinking as, the industry of serious illness and end of life medicine. It hits me there personally. Last visit first is like, I think it's perhaps a place that we come to for, you know, the truth. What's really happening out there, the first place to stop to hear from people who are in the industry who care about the people and the products that serve those receiving that last visit.
Cool.
Yeah.
When we
Did I
were naming
nail
the
it? I
podcast,
don't know.
you did. You did great. You did
Huh?
great. Yeah. Everybody has a different, what that means to them. But when we started writing trying to figure out what the podcast name was going to be, I gave it a whole bunch of prompts in ChatGPT and said, here's what I'm thinking about. Like, I want to build a podcast. I want it to be about end of life. I want it to be about home health, hospice care, and it Last Visit First kept coming to the top of the why are we doing this? And in the real reasoning behind it that we figured out was we want every visit to be like the last visit. And we want to make sure we're providing all that end of life support and care that we need to for a patient, just like it was their last one, because it could be. And so how do we make sure it's their last interaction? So that's where it came from. All right, we got to start wrapping up here, but I have a few more questions for you. What do you want your legacy to be when people look back, when your kids are talking to their friends, and they're the sandwich crowd, and what do you want them to say about your mom? What do you want them to say? Mom was, fill out that sentence. What was your legacy?
Mom worked really hard. She always told the truth. And even when it wasn't cool, she loved creating access for people who were in the throes of serious illness and life transitions. She didn't care about getting dirty, and she never stopped working. Yeah,
It's awesome. It's
yeah.
awesome. I love the work ethic. It's one of the things I learned from my father. He's still to this day, 77 years old, still works as hard. He mows, he weed eats, then he weed eats, then he mows, and he mows, he fishes, still working, still having fun, never gave up, always told the truth, talks a lot. He's a great guy. He tells great stories. He's got a little bit of dementia going on, or Alzheimer's, but he tells great stories. But man, they take a long time. But I love spending time with him, and that's cool. And I hope that that's all true. Your children should be able to brag about how hard their mom worked. That's an asset that not
Well,
everybody
we
has
got
anymore. Cool.
Oh, and I hope they say I was fun. I hope that they say that it was really fun because
That
I do work hard, play hard, you know?
That's right. I agree with that. Um, when are you going to write a book?
I don't know. I feel like, well, that will be one of the solutions one might find within our portfolio of referral partners. I I would love to do that after this particular work, or what would the book be about? I do think it's and I've written about this already for National Hospice and Palliative Care, and it's about the tides of serious illness in America and the impact on culture and decision making and humans. You know, now
Cool.
a book about me, I don't know that I'll ever write that because I might get thrown in jail.
There's a story there I need to hear. Um, yeah. I had Dr. Heather Hodges on the podcast before this, and she's written 3 books, and she's writing her 3rd one. She's got 2 out, and that's amazing to me. I've always said I should write a book, and I don't know what I'd write a book about. My story's not that great. But it'd be fun. And so I've started, over the past 5 years since I left home care, I always started, keeping a journal of things I want to write about and chapters. And I don't know, someday I may publish a book, but we'll
You
see.
should. I think you should. I started one when I was a hospice nurse, like, back in the day. I got divorced really young, and I started one, I would say, in, like, my mid-20s is when it started, and then I wrote for about 6 years in it, and it was like the dating, and it was also as you're being a hospice nurse, and what the beauty of that work taught me about what I'm really looking for in a partner. And I always said the title of the dating, or the book, which would be self-help for single women who are looking for the right person, is "Will He Wipe Your Ass?"
That's funny. It's a tough one. I don't know. Golly.
Or will he pay for it, you know?
Yeah.
So it's
Yeah.
gotta be one or the other. You can't have both.
Yeah. Wow, that's a fun name for a title. I don't know how much Amazon's going to do that, but that's a great name. Well, Katie,
Right.
it's been a blast to have you on here. Any questions you have for me?
I'd like to know what you think when you think of last visit first. What are you hopeful this podcast will achieve?
So it's a great question. And when I was starting to think about, for 5 years, people said, you need to create a podcast. You need to create a podcast. You listen to them all the time. And I constantly I don't listen to music anymore. I listen to podcasts or watch football. I don't watch the news. I mean, I watch the weather, but, and I really didn't want to do a podcast. I was like, I don't want to do that. I don't want to do that. And then I was having dinner with, a group of a customer of ours, and they're like, you need to create the podcast. You can get all the people on there. People like Katy Lanz will come onto your podcast, or April Anthony, or, David Chupin, or, Dr. Hodges. And they're like, you can get those people on the podcast, and people want to hear their stories. And so I started thinking about it for a while, talked to Jennifer for a while. We sat down and discussed it. We prayed about it at church. Should we do this or not? And one of the things that we said is, there's a story to be told here, and people want to hear what these leaders are doing. And I want, by the way, I want aides, I want social workers, I want nurses, I want doctors. I did one with Dr. Mayo and Dr. Richter, who are two chief medical officers at hospices. But there's stories to be told around our industry, and people want to hear what, they want to go deep with them, like we've done with you today. And, you know, who would have thought you were going to write a book called Will He Wipe Your Ass? I mean, that's amazing. But I would never know that. But so that's what really got to us. And, and people are like, are you doing it to make money? I'm like, no, I don't really want to make money at the podcast. I mean, it'll use to support our businesses and our sponsors and all that. But one day I just said, you know what, I'm going to do it. And it's not a legacy. It's nothing like that. It's just, I want to tell the stories. And believe it or not, I actually really enjoy this. Like I talk to people all the time. I'm constantly talking to people and every day, all day long, all I do is talk on the phone or on Zoom or whatever. And I'm like, let's do it. And so I hired Cole Sorensen, who's a podcast producer, and he's done a fantastic job. He runs everything for me. All I do is sit here and talk, come up with some dumb questions to ask people. And, but it's been a blast. We love it. And people are listening to it. People are listening to the podcast. And, so I'm super excited about it. And so at the end of the day, can we share what we're doing? Will people listen to it? If they quit listening to it, we'll quit doing it. But, as long as people like it, we're going to keep doing it. And it's fun. We're having fun with it.
I'm so happy for you guys, you and Jennifer, and what you guys are building. And I hope that we have the most hits on this one. I hope
OB.
this blows the roof. No, I'm kidding. I don't know what'll
It
happen, but I hope
better.
that I'm helpful to you in achieving what you're hopeful to achieve, because this does the plight of the work that we all do and we care about, those of us that continue to show up. And if there's anything I say to anybody out there, it's like, you got to keep showing up. Like people say, how'd you get where you are? Just keep showing up and asking questions and seeking understanding, and more importantly, delivering. And that's what you do, Tom. You and Jennifer,
Thanks.
you guys deliver. And so thanks for putting this opportunity out here for me and other people. And we appreciate it.
Yeah, it's awesome. Thanks for being here.
Yeah.
Have a great day.
All right. See ya.
Bye bye.
Bye.